Hi, my name is Kayla. I'm a first-year psychology PhD student at the University of Sydney, and I'll be discussing ethical considerations on boundaries and the use of touch in psychedelic and MDMA-assisted therapy, specifically in medicalized models of this therapy that we see in clinical research trials. Just a note before we start, I will be discussing sexual assault and institutional abuse throughout this presentation, so just consider that when deciding where and how you listen to this presentation. So a bit of an overview. This quote in the Lancet on ethical concerns for psychedelic therapy captures a big point of this talk. It reads, "The more pressing issue affecting the rollout of these therapies will rise from dynamics between providers and patients." So in this talk, I'm going to first talk a bit about boundaries and the use of touch in regular or non-psychedelic therapy. Then I'll talk about touch, safety, and consent in psychedelic and MDMA therapy. I'll next discuss ethical concerns and abuses involving touch and boundary violations. And finally, I'll present some suggestions to hopefully improve safety in this practice. A bit of background about myself. Before I started my PhD this year, I worked in domestic abuse and sexual assault intervention. And I also worked alongside the Australian government's review of institutional child sexual abuse. So they interviewed nearly 7,000 people who experienced abuse within institutions like schools, foster care, and mental health services. And the findings from this really emphasized how these institutions failed to protect vulnerable people, and that there are, in fact, clear and concrete ways to prevent abuses from happening in the first place. And part of that is recognizing that boundary transgressions and abuses of power are at the core of sexual abuse. And so in the context of psychedelic therapy, we really need to recognize that conversations on touch are inherently conversations about boundaries, and that boundaries are vital to ensuring patient safety and well-being. So what do I mean by boundaries? We often talk about creating a safe container for people in therapy, and boundaries are a big part of making an experience both physically and emotionally safe. So boundaries recognize that there is a power imbalance between the practitioner and the patient, and boundaries define this relationship. So it makes it really clear what services are provided and what is not. Part of ethical boundaries in therapy mean that multiple relationships are avoided, and that means any relationships outside of the patient-practitioner relationship. And it also means that sexual intimacy is never part of ethical practice because it is simply not possible to give consent for sex in the context of that power differential. And the use of touch is generally avoided in therapy because of the power differential and because there's simply not a strong evidence base for its use. Boundary transgressions and violations are one of the most common reasons for complaints against psychologists, though it's likely that there are many that are not formally reported. So it's really hard for us to know the extent to which this occurs. And in general, there's really limited research on boundary transgressions, in part because it's difficult to define, it's difficult to capture this information, and research tends to focus on therapist self-reports, which can be quite inaccurate and different to the experience of patients. And further, in the discourse on safety in psychotherapy in general, it's a very under-researched topic. But we see, for example, an editorial from David Nutt and Michael Sharp that covers the issue of safety in psychotherapy. And it really highlights this idea that we often assume psychotherapy is either positive or neutral. And if it doesn't work, it's just neutral. But we often don't consider the real potential for causing harm with psychotherapy. And interestingly, this editorial actually doesn't mention boundary violations. So regarding the most harmful of boundary violations, sexual boundary violations, this is again very under-researched area. A report on pooled data found 4.4% of therapists self-reported committing sexual boundary violations, though again, it's very hard to get an accurate picture of this figure. What we do know, though, is that there is a significant amount of enduring harm to patients that can include PTSD, feelings of betrayal, exploitation, guilt, self-blame, and a high dependency that forms on the offending professional. So this is our starting point for regular therapy. And then turning to the context of psychedelic therapy, there's very little discussed on boundaries. For example, Johnson et al., one of the most widely cited papers for patient safety in psychedelic therapy, doesn't mention the potential for boundary transgressions or violations, even though this is something that was documented and had occurred prior to this paper being written. So why is touch such a big topic and feature of psychedelic assisted therapy? The biggest reason is that touch can provide a sense of grounding to a patient who is beyond verbal interaction and who needs to hold someone's hand to reorientate their sense of reality. And that's fairly uncontroversial and easy to understand. But there's another dominant view, and it's the idea that it could be harmful or neglectful to not use touch with somebody who needs to be hugged or supported physically, who needs to experience safe touch in order to heal. And before I discuss this further, I just need to challenge this idea and note that it draws into question who should provide this safe touch and when and where should this occur? Is an MDMA dosing session where feelings of love and suggestibility are increased with a paid therapist, is this the best place to experience safe touch? There is literature to support that a skilled therapist can address this need and trauma around touch without having to engage in physical contact with the client. But I will go a bit into different modalities around touch that are connected to psychedelic therapy. So for example, the MAPS manual recommends that therapists have experience with holotropic breathwork or the Hakomi method for treating trauma. Holotropic breathwork was created by Stan Grof in the 70s, and it uses patterns of rapid breathing like hyperventilation to induce an altered state of consciousness. This is a quote from Grof, who theorized on body-based traumas like sexual assault, that the only way to heal this type of trauma is to offer a corrective experience in the form of supportive physical contact in a holotropic state of consciousness. Physical support can range from simple hand holding or touching the forehead to full body contact. And full body contact includes laying on top of people, using your body as resistance as a resistance block for a patient to push against. And I want to emphasize there are many people who find a massive amount of benefit from holotropic breathwork and this practice. However, there's extremely limited research on this form of therapy. And the other one is the Hakomi method, which was developed by Ron Kurtz, and it's based in Eastern spiritual traditions and uses the body's structures to uncover core material through experiments with the therapist. But the MAPS manual and other manuals for psychedelic therapy come back to some similar key points to ensure safety when touch is used in sessions. I'll go over those now. So one is the therapist dyad. Johnson et al. Mentions that having both genders present may foster feelings of security. And this references a psychoanalytic approach of having a mother and father figure for different developmental transference reasons. But I'll note it has been suggested that having two therapists present actually stems from sexual abuses in MDMA therapy that occurred in the 1980s. Rick Ingrassi was a medical doctor who advocated for MDMA therapy alongside Rick Doblin, and he was implicated in sexually abusing a number of clients. So people say that this is actually where why the dyad came about. And there's also very little discussion on how, depending on the dynamic, how the power differential created between the two therapists and their relationship could actually make things less safe for the patient. So it's very much overly simplistic to assume this protects patients. So the other safety method is an emphasis on practicing within the therapist's scope of competence. And some responses to abuses in psychedelic therapy say that the therapists just weren't practicing in their scope of competence, though this is a pretty poorly defined term and has a lot of room for blurriness. The other safety measures that sessions are recorded. This, of course, implies the recordings would be watched to ensure that touch was used appropriately. And finally, there's a strong emphasis on consent to touch, both before and during the active dosing session. So consent, what is consent? A standard definition of consent conceptualizes it as requiring intentionality, competence, voluntariness, and autonomy, and that these are the necessary conditions for someone to provide consent. Of course, when we're talking about the use of psychedelics, we really need to consider what competence means. We know that people are intoxicated by these substances, and psychedelics enhance suggestibility. So because of this, we see an emphasis on obtaining consent for touch both before and during the dosing session. But I think we really need to back up on this conversation on consent and discuss this idea of autonomy. So there's a robust field of feminist scholarship that suggests we can't conceptualize people as purely individuals, that we all exist in relation to others, and that these relationships and power dynamics between people form the conditions for people to exercise their right to self-determination. So what do power dynamics and power relations look like in psychedelic therapy? I'm referring to all of the factors that could potentially create an imbalance in the relationship between the practitioner who's obtaining consent for touch and the patient who's giving consent for touch. So this is just a small list, actually, of factors to consider. I won't go through them all, but I would implore you to consider how we amplify the dynamics of power between practitioner and patient, and how this would impact autonomy, and subsequently how we talk about consent. What do we know currently about ethical challenges in psychedelic healing? Brennan et al. Interviewed 23 underground practitioners, and about half of them had a master's degree in psychology, and they identified some, they gave qualitative interviews, and a number of themes were brought up. A couple of them were that there was actually a greater power dynamic between therapist and client, that there is a deep intimacy, a natural prevalence of multiple relationships, and the use of touch. Before I present some quotes from this study, I want to note that Bill Brennan, the main author of this paper, ended up releasing the raw data from his study after multiple allegations of sexual abuse came out against one of his teachers, Aharon Grossbard, and his wife, Francoise Borzot, who are both high-profile psychedelic therapists and trainers. They founded a training institute that they stepped down from. And Brennan wrote an author's statement, which I'd really encourage you to read. He was very open with stating that some of his work failed to be sufficiently critical of the participants' perspectives, and that this topic really merits further work going forward. So some of the quotes from underground therapists. It's a very fine line going between physical intimacy to erotic intimacy to sexual intimacy. So, sometimes you can cross it. There would be clients where I do the journey sessions in my home as opposed to in my office, which is a big boundary dissolving act. It's so much beyond regular therapy. It goes so far beyond it. They might really fall in love with me or feel just like really close to me, or feel like they really want to be my friend. I think that's pretty common. Sometimes with clients, like, we get revered or put in the status as like godman or shaman. So we know that many people have been harmed by psychedelic therapists. I strongly encourage people to engage directly with the reporting and listen to survivors' voices on this directly. I know that from working in sexual assault intervention, that for every headline, there are a myriad of other cases that aren't in the headlines for any number of reasons. And we need to remember this, and remember that there is an enormous personal toll on those who do make their stories public, and how this impacts their life. So I do really want to give my thanks and appreciation to those people who have come forward. I want to point out some themes rather than discuss specific cases. So first is that abuse in psychedelic therapy is not new or isolated. Many of these reports involve high status figures who have decades of training and experience. We see connections between figures and some key training institutes and patterns of patients turned students turned therapists in a cycle that is reminiscent of psychotherapy cults. And what we see in so many of these accounts is an erosion of autonomy and boundaries under the guise of it being healing and therapy, and that people need to be challenged in order to heal, and that these techniques just aren't understood by mainstream society. And I suggest that there's a prevailing notion of psychedelic therapy exceptionalism, that psychedelic therapy is somehow above established ethical norms and exempt from consideration in the same way as other therapy. And I believe this is a false premise, and that we're actually seeing the same exact patterns of people exploiting institutionally reinforced power to abuse people with far less power. And we've seen this play out across pretty much every other institution in society at this point, between priests and pastors, sports coaches, media moguls. We've seen this pattern before. And I do believe that this type of abuse can be prevented, and it is not an inevitable factor in society. So for the rest of the talk, I'm going to give suggestions for how to improve safety based on my experiences and research. So how can we set up the structures of psychedelic therapy to move forward, to actively try to reduce power differentials, which I want to emphasize will always exist to some degree, but we can try to reduce them. How can we move towards a place where we can actually suggest that people can meaningfully give consent to touch, and what the limits on that are? So I suggest we need to create structures in the research and implementation of these therapies that encourage meaningful feedback that will inform how psychedelic therapy develops. And a great thing about this and about shifting to really encouraging meaningful feedback is that it can improve the delivery of psychedelic assisted therapy, which is currently based on models that are frankly a bit dated and come from a pretty homogenous group of first wave theorists. We've been stuck in essentially one model, and I believe there's a great deal of room for exploration of other formats. And one example is thoroughly reconsidering the therapist dyad and who this benefits. I also suggest that therapist training must directly address boundaries, risks, and warnings of boundary transgression, and there needs to be wider agreement on what this means for the potential rollout of this therapy. And there needs to be clear paths for complaints, not ones hidden in the bushes. We need paths that welcome and meaningfully respond to complaints. And we need to consider how to provide external ethics support and consultation for both practitioners and patients. So how to talk about boundaries? I suggest that we have a responsibility to normalize talking about and actively promoting talking about healthy boundaries and warning signs in therapies. So these are some examples from a red flags kind of checklist. Some examples, sessions frequently run over by half an hour or more. The practitioner often takes former clients on as trainees at their training institute. The practitioner encourages me to telephone them, even if I don't feel I need to. The practitioner talks about other clients in my presence. So these aren't necessarily abusive practices, but they are examples that can be signs of high control environments and abusive practice. And I found that from my work in domestic violence, many people were unaware that they had experienced abuse, that had followed recognized patterns, and that this type of information can help people to orientate themselves in what can be a very confusing and disorientating experience. So we really need this kind of information to be widely shared. And finally, on the actual use of touch. So this is a quote from McCabe, 1977, the original reference from Johnson et al., 2008, for the use of touch. And though Johnson takes a more therapist-directed approach, this one states, some patients show a continuing need to know that they can reach out and touch the guide, This physical access often symbolizes to the patient a lifeline of reality, to reality. And what I really like here is on the emphasis on the patient initiating the touch and the patient having that ability to know they can reach out and have control over touch. We need to be really clear on the goal for non-directive therapy in dosing and emphasizing the ability of the patient to have control over their situation. And particularly for people who've experienced sexual assault, the loss of control is a core harm to this kind of abuse. And we really need to look at fringe therapies like the Hakomi method and holotropic breathwork. We really need research on those that are separate from psychedelics first. And finally, we need to explore innovative other means of grounding and somatic connection that are safer for clients and respect autonomy. So lastly, to summarize, power differentials are amplified in psychedelic and MDMA therapy, and they require more research and communication on touch and boundaries. Abuse is not inevitable, and guidelines and structures of therapy can improve safety for clients. And bystanders have a responsibility to understand this as a shared issue and to learn how to respond to abuse. That means all of us, whether it impacts you directly or not. I will close with a quote from Grace Tame, who is a survivor advocate who has made Australian of the Year for her work on bringing awareness to sexual abuse. She said, "We are all welcome at this table. Communication breeds understanding, and understanding is the foundation of progress." So thank you very much for listening to my talk, and I really appreciate your time.